Hello, my name is Vaskin Dilsizian. I'm from University of Maryland Medical Center, Associate Editor of JACC Imaging. With me today in the studio is Dr. Manuel Sequeira from Cleveland Clinic and Dr. James Udelson from Tufts Medical Center. Gentlemen, welcome.
Thank you.
Pleasure to be here.
Dr. Sequeira, in the current issue of JACC Imaging, you have a multi-center clinical trial where you look at the efficacy and safety of a new A2A receptor agonist called Regadenoson. You also assess this agent compared to adenosine in subset of patients related to age, gender, diabetes, and obesity. Could you first tell us what is the design of the multi-center trial before we get into the results?
The trial basically had all the patients who enrolled, and this was a phase 3 trial where we enrolled over 2,000 patients. All of them had an adenosine study performed at the time of enrollment. Once the adenosine study was completed, patients were then randomized to either get a repeat adenosine or they got a Regadenoson study. And we had twice as many people randomized to Regadenoson as we did to adenosine.
That's great. Dr. Udelson, do we need a new A2A receptor agonist? In essence, what are the limitations of the current vasodilators, adenosine or dipridamole?
Well, certainly where people use them, and 3 million or so tests are done around the United States with pharmacologic stress imaging. The problem has been that they work well, but there's a lot of side effects. With adenosine, probably over 80% of patients will have either chest pain, flushing, shortness of breath, or some combination. A much smaller percent will have second or third degree AV block. All of these are transient, but it can be a relatively uncomfortable patient experience.
That's great. So, Dr. Sequeira, did your results show any improvement in those symptoms?
Well, I think in terms of the symptoms, what we found with our A2A agonist as well as the others is that the occurrence of symptoms is still fairly high. Despite all the animal work looking at the selectivity of the A2A receptors, we do find that heart rate, blood pressure, flushing and chest pain do occur to some extent, although overall, when we looked at both the composite index, we found that they were less with Regadenoson than they were with adenosine.
And within the subset of populations, diabetes, obesity, was there any difference?
Essentially, women were more likely to have any side effects, although the difference, again, between adenosine and Regadenoson favored Regadenoson over adenosine. But again, when we looked at EF greater than 35, less than 35, we found that both efficacy as well as tolerability was better. When we looked at body weight, we also found that whether you were heavy or light, using a fixed dose, because this drug is actually given as a bolus of a fixed dose without weight adjustment, that the side effect profile was similarly improved with Regadenoson.
Dr. Udelson, recently you presented in late-breaking clinical trials at the American College of Cardiology of another adenosine A2A receptor agonist called Adenosine. Mm-hmm. Could you share with us what the results of that study were, and perhaps you can also compare the two, whether they're similar or...
Sure. The trials were called the VISION trials, and I presented two pivotal trials, VISION 302 and 305. The design was a little bit different in that patients who were referred for a clinical adenosine study had both that and the Adenosine study. So every patient coming into the trial had both in randomized order, with all of the imaging parameters held very similar. And essentially, there was similar extent and severity of ischemia seen with the Adenosine as with adenosine, and similarly to the Regadenoson studies in a side effect comparison, which was very rigorously done in a very double-blind way. Chest pain, flushing, shortness of breath were all reduced in incidence, and when they happened, the intensity, which was rated by the patients in a blinded way, was half of what it was with adenosine, and AV block was never seen. We also asked the patients, which of the two imaging sessions did you prefer for the sort of overall patient experience? And in both trials, about 70% preferred Adenosine, 20% preferred adenosine, and 10% had no preference. Very similar in both of the trials.
So these seem to be very promising, and I guess the question remains, what about the asthmatic patients? Have they been studied? If not, when will you think they'll be studied, Dr. Sequeira?
That's a very good question, because I think in both of our trials, those patients were not included preferentially, and then to some extent they were excluded, as well as people had to survive an initial adenosine study so that the incidence of AV nodal block, and ours was very low, similar to what Jim found. But I think we need further trials in these patients. Now, we have some preliminary data in COPD patients with very bad FEV1s that the drug can be given safely without inducing bronchospasm, measured by PFTs.
Dr. Udelson, in your editorial comment, you make an important point about objective analysis. That is, you make a difference between some difference score, which is a way of assessing ischemia visually, versus pure quantitation. Could you comment about the two technical or imaging differences?
Sure. I think what we've learned from both of these programs, I think, and I think the readings were generally similar. When we do image reading in a regulatory environment for trials, you have expert readers looking at images without any other information, having to score multiple segments, and then you add up the scores. There's a lot of inherent variability. The scoring works in general for prognosis in gross patient groups, but when you're trying to compare things head to head, you end up with a good degree of variability, as has been seen with the adenosine comparison in the Regadenoson studies. Now, that's inherent to the technique. It has nothing to do with Regadenoson, Adenosine, et cetera. It's inherent to that way of analysis. So one of the points I made in the editorial was that using quantitation, which is widely available, everyone has the software programs, at least takes away the sort of the human element to it.
That's great.
And theoretically, at least, should get closer to the truth. There's still variability, the biologic variability of coronary flow reserve response to adenosine or Regadenoson or Adenosine, but at least one component of the variability could be reduced in these kind of trials.
Well, gentlemen, it's been quite informative, and we look forward to having both of these traces approved by the FDA, hopefully over the next couple of years, and we look forward to reading more about subsequent trials from both of these agents. Again, wanted to thank you for joining CVN for this very informative session.